Welcome to the ICU Podcast, where we explore the vestibular experience through conversations between patients and the health professionals who care for them.
During this podcast, we invite patients to share their stories and healthcare professionals to ask questions so they are equipped to better care for and truly see the invisible challenges faced by their patients. I'm Kimberly Warner.
And I'm Cynthia Ryan, and we are your hosts on this journey of discovery. Well, welcome everyone to another episode of the ICU Podcast. Today, we're going to talk about what happens when we lose function in our inner ear completely, when the vestibular system on both your right and your left sides is not working. Bilateral vestibular loss, also known as hypofunction, can be devastating. It results in severe difficulty maintaining balance, especially when walking in the dark or on uneven surfaces, and a decrease in your ability to see clearly when moving your head. This can lead to an increased risk of falling, blurry vision, dizziness, imbalance, and can eventually lead to other types of physical deconditioning. How does a person cope with when their internal gyroscope is essentially turned off, and what medical miracles are available to help them? Our guests today are Dr. Charley Della Santina, one of the foremost researchers in this area, and Donna McKinney, a vestibular patient with bilateral vestibular loss. I'm going to start by introducing Dr. Della Santina. He specializes in surgery for treatment of otosclerosis, acoustic neuroma, and other problems that cause hearing loss or abnormal vestibular sensation. He's a neurophysiologist with PhDs in biomedical and electrical engineering. Dr. Della Santina founded and directs the Johns Hopkins Vestibular Neuroengineering Lab. His research there focuses on developing a vestibular implant to treat chronic unsteadiness and oscillopsia caused by gentamicin ototoxicity and other causes of bilateral vestibular hypofunction. Welcome, Dr. Della Santina.
Well, thanks for having me.
That was a mouthful, Cynthia. I'm impressed.
There's a lot of stuff going on here.
So I'm going to introduce our patient guest today. Donna McKinney is here with us. She is a mom of 3 and a proud grandmother. Since her diagnosis of bilateral vestibular loss in 2014, she has had to retire from her physically active career as a youth and senior fitness director. She has become a certified health coach and a diabetes prevention coach and is hoping to return to work on a part-time basis. Donna enjoys cooking, spending time with her family, going for long rides and day trips with her partner, Alec, who has been by her side through every dizzying step of this diagnosis. In May of last year, Donna received the multi-channel vestibular implant as part of a study at Johns Hopkins University. We cannot wait to hear more about this. So welcome, Donna.
Thank you. Thank you. It's a pleasure.
It's really great to have you here, and considering all of you've been through and your more recent developments with the surgery. Let's back up though a little bit first. Tell us a little bit about your vestibular journey. Did you lose your balance suddenly, or was it more of a gradual process?
Mine was more of a gradual process. I didn't have an exposure to an ototoxic medication. I had history of vestibular migraines. Started off with classic migraine, developed to vestibular migraine, and then over the course of maybe 12 to 18 months, I started getting more severe bouts of vertigo. And once it finally I think that was sort of as it was described to me, I was losing that vestibular function sort of unilaterally, then bilaterally, and it wasn't really going evenly, or at least that was how it was originally described to me, which was causing the really bad vertigo. And then once everything kind of crashed, then it was fairly sudden. I woke up one morning, had a horrible bout of vertigo, hit the ground, tried to stand up, everything was bouncing. It was just, my world literally within that 24 hours kind of turned upside down. But it was a long process up to that. Like, I noticed I was failing some of the balance tests that I would give to other people. I was struggling with my vision, especially at night, trying to drive. I thought it was older age, maybe cataracts or something, but I was fairly knowledgeable in the vestibular system, but didn't really know how much it would impact my vision. And so when the vision went, I knew there was something was really not right.
Wow. That sounds so intense.
Yeah.
It was a lot. It was a lot.
I don't know which would be better, having it come on all of a sudden or having it come on gradually. I think it's, they're both challenging when you're dealing with full loss of your balance and literally not knowing which way is up.
I think if it would have come on a little bit more suddenly, I would have maybe been a little bit more aggressive about treating it, because in the beginning, I just thought I was having migraines, and, I just kind of chalked it up to these are vestibular migraines. This is who I am. And it wasn't really until the visual aspect of it came into play, and that really one awful morning where I was like, okay, I knew it wasn't, I have enough of an education in medical field. I knew I wasn't like having a stroke or anything like that, but I knew there was definitely something wrong with my vestibular system that was more than just a migraine. So,
wow. Right. That makes a lot of sense. Well, Dr. Della Santina, can you tell us a little bit about your professional background and how did you start to specialize in developing treatments for vestibular loss?
Oh, yeah, thanks. I currently work at Johns Hopkins. I'm a professor of otolaryngology, head and neck surgery, and biomedical engineering. So what that means is that my practice is a surgical practice treating patients who have ear disorders, either hearing or balance. And I run a lab that is mostly made up of PhD students in biomedical engineering and some clinician fellows. The way I got to where I am now is starting with training as an electrical engineer. I just have a bachelor's, not a PhD in electrical engineering. But then from there, I went into a PhD program in biomedical engineering. Biomedical engineering is a pretty broad field because it more or less means engineering applied to biology or medicine. And for me, that meant neuroscience and studying how the inner ear works, using some electrical engineering techniques that now, 30 years later, are kind of coming to fruition, where people are micromachining silicon devices to implant into neural tissue. We were doing that in the 90s in a sort of more basic way. When I then shifted and went into medical training, I started looking for a specialty within medicine that would allow me to kind of bring my different interests together. And, in research, I had focused on the inner ear, and in my clinical experience, I've met a lot of patients who have disorders of hearing or balance, and it's a very impactful problem. People don't die of ear disorders generally. This isn't a life-threatening issue, but it really impacts people's ability to interact with their friends, their family, with people at work. And so it can be a really gratifying field to work in because you can make a big difference in someone's quality of life. Yeah. Sometimes with an operation that takes a couple of hours. So that attracted me to the field. And it also happens to be a field where there's a ton of research still left to do. On the hearing side, we're 40 plus years into development of cochlear implantation. That's a very mature field. But on the vestibular side, even though there's been over a century of great research in vestibular physiology, there really hasn't been nearly as much work at trying to restore vestibular function. And so it's kind of a wide open vista for looking into new ways to study how the nervous system works and ways that you can improve its function and help people who've lost sensation.
A wide open vista with hundreds of thousands of patients, if not millions, behind you, going, rooting you on.
Yeah, it's funny when you think about it. Everybody knows about hearing loss. It's easy. You can. Everyone's experienced some degree of hearing loss at some point in their lives. We have words in English. You can have deafness. Everyone knows what that means. Everyone knows what it means to not be able to see. And close your eyes. You can simulate it. And we have words like blindness. For vestibular function, most people aren't even aware that they have it, and they don't know it's there until it starts going wrong. And once it's lost, most people aren't even aware of what the symptoms that would even be. There's no word in the English language for it. It's frustrating for us because we use terms that are clunky, like bilateral vestibular hypofunction, because it's just not so common in experience that we have, vernacular words for it. The way that translates for our patients is that patients, they think that they're just going crazy, or they think that they're becoming clumsy, or they think there's some other deficit of the way they are that nobody can see, and most of the clinicians they interact with early on don't understand or don't remember from their half hour in medical school about it. So it's a really impactful problem, but it's a kind of a silent problem, except for the people affected.
Wow. It sounds like you bring a lot of compassion to your practice.
Yeah.
Well, I mean, I think you can't help but be compassionate when you meet people who've lived through this type of problem, like what Donna was describing.
Yeah. Actually, Donna, let's hear a little bit about those early days. I'm imagining with your blurry vision, feeling like you're going to fall over all the time, vertigo attacks. How were you coping in those early days?
Honestly, I think in the beginning, some of it was just frustration and anger because, like Dr. Della Santina was saying, I was having a really hard time getting a medical professional to really hear and understand what was going on. And my primary care physician had actually said, I'm sorry, Donna, I don't really know what's going on. I'm going to have to drop, her literal words were, I'm going to have to drop back and punt. And I was like, punt me to where? Punt me to who? And, insurance issues abound, or were at that time anyway. So, getting treatment was just really frustrating. And so I think just that I'm persistent. And so in the beginning, my coping strategy was like, I'm going to get answers. I want to know what's going on. I'm going to push myself through this. I'm going to get better. And then when I realized that this was as good as it's going to get, after talking to a few different specialists and seeing a few different people, it was like, okay, this is my new normal. And so how am I going to live with this? And my physical therapy went from focusing on improving my vestibular function, because that wasn't going to happen, to how can I live safely with vestibular function. So, making changes to my living environment. I got a good counselor, because having somebody to talk to, third party that wasn't family, that I could vent to, was really critical. And that helped me a lot. For me, one of the bigger issues was my fight or flight would just go off. I'd be in the middle of a grocery store, and all of a sudden that overwhelming feeling like you're going to fall, everything's bouncy, the sensory integration, it'd be so overwhelming. And, you try and suppress that fight or flight, and I wasn't doing it very well. So meditation and cognitive behavior therapy, those types of things really are, I think, what got me through learning how to fall properly. Having a good physical therapist that said, I feel for you, but we're not going to be able to get you any better vestibular function, but we can make you safer. And so I think that's really what got me through those first few years, was just having a good supportive team that gave me the coping strategies, teaching me I normally don't have my blinds down. I normally first thing in the morning get up and pull those up, because the lines coming through on the floor would be terrifying. But with the new vestibular implant, it's a lot easier. So,
Oh my goodness. You probably don't know my story, Donna, but I have malday debarkment. And so I know a version of what you're talking about,
right.
But they're also very different, but I relate especially to that inability to, when the nervous system says, I'm in danger.
This is it. Yeah.
This is it. There is not a lot we can do. With time, we learn that we're not, but that nervous system and the panic response is so strong and so powerful and so all encompassing. So I feel for you when you were sharing that.
It can be very isolating, because, your friends are still going out and doing their things. I was in my mid 40s. I was very healthy. I was very active. And then, all of a sudden it's like, walking to a grocery store is overwhelming, much less trying to go to a ball game or a park with squishy ground or uneven, things. And so, it can be very lonely and very isolating. And so just I got involved with a bilateral vestibular support group on Facebook, which was a huge help too, because it gave me that support. I felt heard, I felt understood.
Yeah.
So, I mean, just surrounding yourself by people who can support you and uplift you and understand, like you're saying, that's really, and like Dr. Della Santina was saying, it's not a very well understood or talked about disorder. And so there's not a whole lot of people out there to reach out to. And so finding that support group and finding Dr. Della Santina has been just life-changing.
Yeah. So we've heard from Donna about the experience of having bilateral vestibular loss. Dr. Della Santina, can you tell us what causes bilateral vestibular loss?
Yeah, sure. It kind of depends on the answer depends on who you ask, because patients end up seeing different clinics and different specialists. If you ask an otolaryngologist, an ear doctor like me, then about a third, maybe almost 40% of cases that I learn about are ototoxic, which means that they're due to a drug, generally an aminoglycoside antibiotic. Gentamicin is the one that most commonly is talked about, but there are others too: tobramycin, streptomycin, and then there are others like amikacin, kanamycin. They're not so commonly used anymore. So ototoxic injury, either due to an antibiotic that you might have received for an infection in the abdomen after an abdominal surgery, for instance, or sometimes a chemotherapy drug can be toxic to the inner ear. Ototoxic makes up maybe, like I said, about a third, maybe almost 40% of the patients that I ultimately talk to. And roughly half of all the patients I talk to, I would say, have idiopathic loss. We don't know what the cause is. And I would guess that the majority of those situations are related to some mix of genetic changes and environmental factors that we just haven't identified yet. And then the rest of people are a mix of various things. So, you could have an injury, you could have a trauma that knocks out function to both ears, although that's not very common. You could have meningitis or other infections that can hit both inner ears. Or you could be a person who was doing perfectly fine, living your whole life with one labyrinth that was working, and maybe you were born without a working labyrinth on the other side. There's plenty of reasons for that to have happened. As long as you have one working labyrinth, you're doing fine. But then maybe something happens to that one side, either a trauma or an infection, or there's some really sad cases in which patients were deliberately poisoned in an attempt to treat what was thought to be Meniere's disease. I'm sure some people who listen to this podcast have had Meniere's, have talked about the use of a medicine like gentamicin deliberately injected into the middle ear in an attempt to try to tamp down vertigo episodes from Meniere's. And that can be a very effective therapy in certain cases, but it should never be done in both ears or in the only remaining working ear in a person who's already lost function on the other side. And that does sometimes happen. I think it happens by very well-intentioned clinicians who are doing the best that they can with a patient who has horrible vertigo attacks and maybe got a good response from gentamicin on the first side. The trouble is that you inject the second side, and now you've converted a person from vertigo attacks to having these symptoms of bilateral vestibular loss. I just want to mention that one other source of ototoxic injury that I hadn't really encountered before the past few years is knee replacements and hip replacements. It's common for orthopedic surgeons to use a bone cement that has an aminoglycoside antibiotic. Usually it would be tobramycin mixed into it. I think the orthopedic surgeons are really worried about infection of a knee replacement or a hip replacement. So they have good reason to have an antibiotic. But the antibiotic that they often use is toxic to the inner ear. And I think that you can get away with it in many cases, but particularly in certain patients who have a genetic predisposition to be sensitive to aminoglycoside antibiotics, that can knock out your inner ear function and hit your kidneys at the same time. And at least one of the participants in our trial, I see that pattern. Patients had a couple of knee replacements, and each time has symptoms of a hit to the vestibular system and to the kidneys. I hope that in the future, orthopedic surgeons become more aware of this risk, because they're unknowingly, I think, putting people at risk of bilateral vestibular loss.
Wow. Thank you for sharing that, Dr. Santina. I hope that some of them are listening today, or maybe we could send this podcast out to some of the medical schools, because like you said, they're probably unknowingly doing this with such great risk for the patient. Donna, I'm going back to thinking about you in your 40s, and you were pursuing a driven sense of, I'm going to get better from this. I'm going to figure out what's going on for a couple of years. And then you just had to surrender and go, I have to learn how to live with this. What was that like for you? I mean, I imagine that impacted every aspect of your life and your relationships. And then on the heels of that, you learn about this vestibular implant clinical trial. And I'm kind of curious, like, were you just no hope left, and then you hear about this and the hope comes back, or what was that like for you?
I never gave up hope. I mean, like, I always hoped that there would be something that was out on the horizon. And at the time that this kind of started happening, I just finished my master's, so I still had access to PubMed and a lot of research articles. And honestly, kind of in the beginning, sort of tried to diagnose myself with going through all those articles, because I wasn't getting very far in the medical community. And I started coming across some of the articles that were written by Dr. Della Santina and other people about, potential hope, and spoke to a clinician who had laid it on the line, said, your only hope is really either stem cell research or some type of a vestibular implant. And we know of a trial that's going on over at Johns Hopkins. And I was like, I think I've heard of his name. And so I think I hopped on and actually applied pretty early to the trial. I think I was like the 31st person who had got my name in the ring there. So I never really lost hope. But it was very frustrating at the same time. You know what I mean? It was just very good days and bad days. It's hard. Like I said, there were great coping strategies. I have a wonderful family. I have a wonderful support system. They were there through all of this. So that helped a lot in getting me, motivated to keep going. But then my cards were all in for Dr. Della Santina and his team and the research that they were doing over there. So I never gave up on that.
Cool.
So I'm interested. I want to hear more about the vestibular implant, but I'm also interested, Dr. Della Santina. First, are there any non-surgical treatments for bilateral vestibular hypofunction? And then on the heels of that, what does this vestibular implant do?
Sure. Yes, absolutely. There are treatments that don't require surgery for loss of vestibular function. I think you can think about it a bit like hearing loss. If someone has hearing loss, the first answer is not a cochlear implant. The first answer is to try to address their hearing loss the best you can. And often that means a combination of hearing aids and maybe auditory rehabilitative therapy. With vestibular loss, I think we need to distinguish between partial loss of vestibular function and really severe or profound loss of function. If somebody's lost some vestibular function, whether it came on quickly or if it progresses slowly, often you don't need any treatment at all. Your central nervous system is really great at adjusting over time to changes in how your vestibular labyrinths are working. And you can completely lose one ear, and after a period of having terrible vertigo for a few hours and feeling really wobbly for a few days and pretty wobbly for a week or two, you'll rapidly adjust to the point where your unilateral loss, your single side loss of vestibular function, by a few months out, you can be back to your normal life and barely notice it unless you make a quick head turn toward that side. If you lose function in both ears, and it's a pretty severe or profound loss, then you just don't have much signal coming in from your inner ears, and your strategy has to be to start using other parts of your nervous system to step in. So for keeping your eyes on target, you can use prediction. When you go to make a head movement, you're going to make the head movement, and your eyes can learn to jump ahead and land where they need to land. You can use the sensation from your neck muscle stretch receptors to signal that your head is moving, and that reflex from your neck muscle receptors to your eye muscles can help keep your eyes on target. You can follow moving targets using a system called Smooth Pursuit. You have all sorts of tricks that you can bring to bear. And through the coaching from a skilled vestibular rehab therapist, you can learn to do even better than you would do just on your own. It's a bit like if I want to learn tennis, I can get pretty good at tennis, I suppose, by just practicing a lot. I could probably get even better if I work with a skilled coach who can see how I'm doing, give me some directed guidance. And I think that that's what vestibular rehab therapists are excellent at. So our mainstay of treatment for vestibular loss is vestibular rehab therapy, and that's been shown time and again to be effective. The other thing you want to do is to not make things harder on yourself. So if you have vestibular loss and you're relying on your vision to keep things on target, or you're relying on the sensation of the soles of your feet, well, then it's probably better not to wear progressive bifocals that distort your visual field. And it's probably better not to wear squishy shoes that make it hard for you to feel the floor as you're walking. Or conversely, to wear such hard-soled shoes that every time your heel hits the ground, your head bounces and you can't see. So there are simple things that you can do that aren't treating the loss of function, but they're making it easier for you to live your life. Things like making sure that you don't have tripping hazards in your house and you have night lights in your house are probably more important to protect you from a fall that could lead to an injury that really changes your quality of life than most of what medicine has to offer. Now, for people who have done all they can with vestibular rehab therapy and they've reached a plateau of their ability to compensate, and they've done all they can to make their life sort of adjusted to what their capabilities are, then no, there isn't a treatment. There's no surgery I can do that makes your labyrinth work again. And there's no stem cell therapy that is going to work. And I don't think stem cells are going to be the path to getting restoration of function. There's been some great news about gene therapy in the past year. There's an otoferlin gene replacement trial that has shown some real progress in helping people hear. But if you look at the stories about it, that discussion is all about hearing. There's no discussion about restoring the vestibular system. And I think that gene therapy for vestibular function will come along in the future, but I think it's a long way off, especially if you're an adult who lost function. So I think our best path forward is vestibular implants.
I love that you have so much to say about things that people can do to accommodate their vestibular loss that don't require medical treatment. I mean that also with guidance from a physical therapist, but there's so much that you can do on your own. Is that right?
Yeah, the other thing I should mention is don't make it worse. So there are so many things that people do. There are things that people are prescribed by their clinicians that just make it worse. So pretty much anything that makes you sleepy is going to make your ability to compensate for vestibular loss worse. So that's medicines like meclizine, which are routinely prescribed. If someone says, hey, I'm dizzy, it's quite common you'll be prescribed meclizine. And taking meclizine is better than having a terrible vertigo attack, but it just makes you more wobbly and less able to compensate. So long-term use of meclizine or benzodiazepines, things like Xanax or Valium, those are just counterproductive, as is alcohol, frankly. And then along the dictum of don't make it worse, well, if you have vestibular loss, then you don't have an allergy to gentamicin, But whenever anyone wants to prescribe you a medicine, you should raise your hand and say, hey, you know what? I have an inner ear problem. Is this a medicine that might be bad for my inner ear? That's really all you have to say to any clinician you interact with. And that'll trigger their memory to ask, hey, wait, maybe I should choose a different antibiotic for this patient since she asked about it.
Wow.
Yeah, and I will say one of the very first things they wanted to do that they did when I was first coming down with the really bad symptoms, the very first thing they did was put me on Klonopin. And it just made things, so I think that was sort of what was slowing me down from really being able to like get full use of my physical therapist. It was like, oh, it's just anxiety, or here we want to calm, the vestibular. And at this point, vertigo was no longer an issue. It had stopped. And I was just left with the imbalance and the oscillopsia, but it was still their first line of treatment was to give me clonazepam. And, once I stopped taking that, I did make a little bit of progress with physical therapy. I could tell that it made a difference. So I think that's one of the other things too, that most primary care physicians aren't maybe familiar with, or don't realize how much of an impact that can have on slowing down your vestibular rehabilitation.
Yeah. Donna, I'm really excited to hear about pre-implant Donna and post-implant Donna and what that was like. But before we do, let's just hear from Dr. Santina again quickly, not quickly, however long you want to take, about what does this implant actually do?
Okay, all right. So we're talking. I'll focus what I say on the vestibular implant system that we use in the trial that we're doing here at Johns Hopkins. That's the Labyrinth Devices MVI multi-channel vestibular implant. It was co-developed by Labyrinth Devices. Full disclosure, it's a company that I founded, so I have a conflict of interest. And Labyrinth Devices partnered with MedL, a well-established cochlear implant manufacturer based in Austria. The device that we're using is a vestibular implant focused on stimulating the semicircular canals, which are the sensors of head rotational velocity. This device does not stimulate the cochlea, or at least it's not intended to. And this device is also not designed to stimulate the utricle and saccule, which are another part of the inner ear that normally measure which way gravity is pulling or other linear accelerations. We are doing that in my laboratory with animals, but the device that we use is a vestibular implant. Some people may have heard of the vestibular cochlear combination implants. There's work on that in Geneva, in Maastricht, in the Netherlands, in Seattle. And there's a group in the Canary Islands that is doing a kind of a combined cochlear implant and vestibular stimulating device. All of those are predominantly cochlear implants being put in the ears of patients who have hearing loss. And then also there are electrodes that are being put into the semicircular canals. We're not doing that now. I think these technologies will converge in the future. But for now, we focus on the semicircular canals. What the vestibular implant we work with does is, I think, easy to understand if you know anything about cochlear implants, where there's a microphone on an outside processor. It measures sound coming in, breaks it into different frequencies, transmits a signal to the implanted stimulator, which then passes current pulses through different electrodes that are meant to represent different frequencies of sound. With a vestibular implant, instead of a microphone, you use a head motion sensor that's measuring the rotation of the head in different directions. You move your head in 3 dimensions, and so it's got 3 channels of information that it's sensing. It conveys that to an implanted stimulator, which is really just a modified cochlear implant. And then its electrodes don't go into the cochlea, they go into the ampulla part, the place where the neural structures are in each of the 3 semicircular canals in the ear that we've implanted. And this device breaks your head motion down into 3 different spatial components, and it stimulates each of the 3 semicircular canals to modulate the activity on each canal's branch of the vestibular nerve in a way that kind of mimics normal physiology. And we know a lot about the code that we have to use and what neurons normally do when you move your head from decades and decades of research throughout the field. first in animals and now more recently in people.
Wow.
It's funny when I was reading your introduction, your biology and your background, and you were talking about your background in engineering, and I was thinking, okay, engineering, medical, how does that all go together? And now I know where the engineering comes in this building of this device, understanding the biology of the inner ear, and then building this device that interacts with it. It's fascinating.
Yeah. Well, this has been. I started on this work around the year 2000 or so. So I'm more than 20 years into it. I think that as far as I know, the first group to publish a paper about anything that was a vestibular implant was Wong Song Gong and Dan Murfeld in Boston at Mass Eye and Ear, where they made it kind of a one-channel sensor of head motion and then planted it on the head of a guinea pig. It's interesting to think, Greg, why did it take until the year 2000 for us to start working toward vestibular implants when we as a field have been doing cochlear implants since the 70s or 80s, and it became a part of routine clinical care in the 90s, maybe the 80s. I think part of it is that microphones already existed that were small because people had hearing aids. And hearing loss was a very common problem, and it's extremely impactful for children who are born without hearing. And so there was the technology available, and there was a very strong drive to make cochlear implants. For vestibular implants, it really wasn't until, cell phones came along that companies started making little motion sensors that were small enough to serve the job that a microphone does on a cochlear implant and don't consume too much power. It used to be the sensor for head rotation was so big that this would be kind of an unworkable thing to do. So miniaturization of the sensors helped support this. And then, 2 to 3 decades worth of cochlear implant technology development gave us a huge leg up. And so developing vestibular implants is this great opportunity where an engineer can come into it and have all of these well-developed tools to assemble together and apply to a new problem. So as an engineer, I found this to be a really fun and interesting line of work to be involved in. And it's nice that it meshes with, a problem that's really under-addressed. There are a lot of people who really need help with this, and we have the tools to help them.
I love it.
Yeah. So Donna, what are the results?
It's been pretty amazing. It's not, necessarily an easy journey right off the bat. You gotta, and I think everybody's experience is a little bit different. And one of the best pieces of advice somebody had given me was, be patient with yourself, and you're likely to mourn something. You're not sure what that's going to be going into it, and the benefits are so much more than anything that I've mourned. My hearing is good. My balance is getting better all the time. I do work with a vision therapist because, as Dr. Della Santina was saying, our vision is so important. I work with a vestibular therapist. And I think for me, one of the biggest differences I see now is when I worked with a vestibular therapist and vision therapist before, because I got, out the gate, I started working with those to try and get better. I could only get so far, and like I said, they got to a point where this is as good as we're going to get you. Learn to live your new normal. Now it's different. Now I can see every time I go in, I'm better. Something I can do is better. I can stand on a wobble board and bounce a ball where I couldn't even have stood on a wobble board before. I can stand on a Bosu ball. I went to the beach for my birthday and I walked across. Now, there were areas where I had to use my cane, but for the most part, I was able to walk across the soft sand without a cane. I went into the water without a cane. Dr. Della Santina made sure that my device was clipped up, so everything was good. I only went to my knees or I sat down, but before, even just the reflections off of the waves without even being in the water were enough to make me unstable. I'd have to grip onto 2 people, 1 on each arm, to walk through that. And now I'm out there doing it by myself. And so the device has given me the ability to live a much more independent life than what I was living before. I can live with a lot less fear. My fight or flight has calmed down. I can make it through an IKEA. I can make it through a Home Depot. I can make it through the beach, and it's not without its challenges. I mean, I still have bad days, weather changes and stuff, but overall it has, I'm glad I didn't lose that hope. I'm glad. And even now, I think I'm even more hopeful now, just because I can see that even though I'm a year out, there are still days where I can wake up in the morning and be like, wow, I'm better today than I was yesterday. Just giving me that. Sorry, I don't mean to get emotional, but even my family, they're like, you're a different person. COVID was really hard on us. Like, one of the most important things I think I found is that if you don't use it, you lose it. And throughout COVID, it was so easy to just sit back and not use it, and now it's like I use it every day, and every day I get a little bit more benefit from it. And it's just been it's a hard journey, but it's a well worth it experience.
Wow. It sounds, so I think a lot of people, when they're thinking of, a surgical procedure, they think of it as a cure-all. And it sounds like this isn't, like you get the surgery and you're better. It sounds like it is a tool in your toolbox to help you on that journey that other, people with maybe unilateral vestibular loss have. You still have to go through the vision therapy and the physical therapy, but as you said, this is a tool that helps you to do those better.
Yeah, and I think the device does a lot. So I don't know if formal therapies would make a difference for other people. I feel like for me it has, because I have somebody out there who's able to physically support me through those, especially in the beginning when I was kind of having to relearn to walk with one-sided input and feeling a whole bunch of things that I hadn't felt in a long time. Having that person that was educated and experienced in that by my side made a big difference, because they were there to give me the strategies to be able to do it properly. Mm-hmm. Does this work on its own by itself? Sure. But I think that training it puts you through that little extra bit. So, I mean, I guess technically I'm unilateral now, because I've got it coming from one side, and it's not perfect, but it's so much better than what it was before. So much better. Yeah. I mean, I thought, Dr. Della Santina probably got frustrated with me, but when they turned it on, I was like expecting it just to be on and to be like, bouncing out of there. And it don't quite work that way, but it does work, and that's what matters.
Well, Dr. Della Santina, research takes a long time. I know that you've been working on this a long time. When will this tool be available to vestibular patients as a part of, their potential treatment plan? And is it meant to treat only bilateral vestibular loss, or will it be used to treat other types of vestibular disorders as well?
I had a few things to say. First off, I wish I could tell you that I know when it will become widely available, but I will not know that until it is widely available. It's hard to predict. And the reason for that is that I've learned now over the past 20 years that there is a huge difference between research and development. Really, I used to just think research and development, or R&D, was just one compound word, and they kind of were the same thing. But they're very, very different. Research is what we do, for instance, in my laboratory. When we do an experiment, or when we develop, kind of create some circuit to do something, we're doing research. We're working under a different set of constraints. Medical device development is an extremely rigorously regimented process that takes countless hours from often a very large team of people. And thanks for saying I've been working on it. I have, but I am just one of many people on the development side of this at Labyrinth Devices, but a much larger team now at MED-EL. And the difference here is that when you're developing a medical device, the process that is designed for a good reason, it's very similar to the process for creating a a rocket that's supposed to go to the moon or to create a commercial airliner. It's a highly regimented process that involves many, many cross checks and balances, and that's even before you get to regulatory review and oversight. So I can't tell you with accurate knowledge when this will be available widely until it is. But I can tell you that everyone involved in this work we're working as fast as we possibly can to bring it to fruition. Unfortunately, FDA approval in the US or CE mark approval in the European Union or elsewhere, that's not the only hurdle. Once you get approval from regulatory agencies, no one can get a treatment until that treatment is covered by, in the US, it has to be covered by Medicare or Medicaid services, or it has to be covered by private insurers. And that creates a whole second set of hurdles that we'll have to navigate past. So that's why there's so much uncertainty in the answer to your question. But I can tell you that it'll be just as soon as it possibly can be. And I think that it'll be soon enough to impact the lives of many of the people who listen to this podcast.
Wow. And I think that one of the things that it, you were saying, Donna, that it gave you hope. And I hope that that's what the people who are listening today will get out of this, is there is hope. And not only with this treatment, but there's hope that people like you, Dr. Della Santina, and other researchers are pursuing other research into other treatments for vestibular disorders that will improve quality of life for people like Donna.
Yeah, that's a point I'd really like to emphasize that we haven't touched on in this discussion, that just generally as a clinician, it's hard to try to work with patients who you cannot help. You can console and you can try to guide them to someone who can help them, but when there's no option to really help them any more than they've already reached, it's disheartening. And for that reason, patients, I think, get lost in the system. Clinicians don't seek out people with bilateral vestibular loss because they don't have a treatment to offer them beyond the rehab they've already had. And when there's no treatment for something, there doesn't seem to be a very strong desire to detect it or diagnose it or to study the causes of it. I'm hopeful that with the development of treatments for vestibular loss, whether it's a vestibular implant or maybe in the future gene therapies or a mix of both, I'm hopeful that that will drive research to better understand why half the people with this problem have idiopathic loss. Half the people with this problem, we don't even know what caused it. And I think we could do better as a field, and I think we will once we have something to offer to help treat it.
Yeah.
I think,
what a testament to your humanity, Dr. Santina, and your compassionate heart, because I feel hopeful just listening to you, knowing that there are physicians out there that are, that they feel that challenge of wanting to care and treat, and sometimes being up against a wall, but still pursuing whatever they can. So thank you from all of us for what you're doing.
For sure. Thank you. Because I know I just wanted to add that, Dr. Della Santina and his team, they're amazing. They've been great. But there were several physicians, including a couple of neurologists that I saw who, without ever even seeing me, refused to see me just based on looking at my calorics. And, like I had an ENT who did a basic caloric test and said, you need to see a neurologist, and they wouldn't even see me. And it just made me feel very, not worthless, but, just kind of like, well, why? Why wouldn't you just take the time? And I think Dr. Della Santina is giving hope to patients like me, but also hope to other physicians that there might be something on the horizon for them that they can do for patients like myself. And that's huge, because I know there's so many other people that I've spoken to, other vestibular patients who are just, they feel unseen and they feel unheard, and they've been turned down by so many other physicians saying, we won't even see you because there's nothing we can do for you. And we don't want to have that, like Dr. Della Santina was saying, it's hard to work with somebody you can't heal, or that you don't have a treatment to offer them. And, so I'm grateful, so very grateful for him and his team, because they are keeping hope alive for a lot of us. it's been a really wonderful experience.
I know that someday this will be the standard procedure.
I hope. I'm hoping they can do it in both ears at some point.
Yeah.
Yeah, I hope you're right, and I think it will become a routine procedure, a lot like a cochlear implant in the future. And when it does, I think that everyone should look back to the study participants, the patients, who really took a leap of faith. I mean, they are pretty much like astronauts, people who stepped in and said, "Yeah, I'll undergo this new implantation of a new device." And I know you don't know enough about how it's going to turn out for me, but I'm willing to step up. I really admire Donna and all the other participants in our trial and others like it. Without whom we wouldn't make the kind of progress that I think is going to end up making this a treatment for people who need it worldwide.
Yeah.
Absolutely. Absolutely. Thank you, everyone out there who has ever participated in a clinical trial, for helping to advance science and knowledge. And for those of you who have ever considered participating in a clinical trial, know that even if you don't receive benefit from the treatment, or knowing that you in some clinical trials might be one of the subjects receiving a placebo, you are making a difference.
Yeah. Thank you both so much for today. This is just such an inspiring conversation.
Yes.
Thank you for having me.
And for sharing your story and your expertise.
And thank you for your leadership in the field. Getting the word out and helping people learn about this is a really important contribution. Thanks for your effort on that.
Absolutely. VITA is a wonderful, wonderful organization. They've been incredibly helpful, not just to myself, but a lot of people that I've referred them to. So thank you for what you guys do.
Oh, thank you. It's so wonderful to receive that feedback. Another great episode, Kimberly.
Yes. Yay.
All right. Thanks again, everyone. Thanks for tuning in to ICU this month.
We hope this conversation sparked new understanding of the vestibular journey. And for all of our patients out there, leaves you feeling just a little more heard and a little more seen. I see you.